This is the continuation of the hypertension and dyslipidemia lecture. So this is the dyslipidemia part. Dyslipidemia or hyperlipidemia is elevation of the plasma cholesterol, triglycerides, or both, or a low HDL. Contributes to the development of cardiovascular disease, and there's a positive correlation to the risk of acute coronary syndrome. Signs and symptoms: symptomatic vascular disease, CAD, stroke, and PAD, you will see with elevated cholesterol levels. High levels of triglycerides can cause acute pancreatitis, issues with the spleen, shortness of breath and confusion. Severe levels greater than 2,000 milligrams can show creamy white appearance of the retina or milky appearance of the blood plasma. High LDL levels can cause dysfunctions of the cornea. You can have fat deposits around the joints and rich yellow plaques on the medial sides of the eyelids. Lipid profile, total and HDL cholesterol can be measured in the non-fasting state, but patients should have all lipids measured while fasting for maximum accuracy and consistency. They should fast for over 8 to 12 hours. Screening starts at the age of 20 and then every 5 years after that. Lipid profile should also be drawn 2 to 3 months after starting treatment, then every 6 months thereafter. A definitive age which a patient no longer requires screening has yet to be established. However, if you have patients that are quite elderly, the risk benefit ratio is quite low. So in those patients, we usually don't continue drawing lipid profiles. You need to remember, don't draw a lipid profile until after the resolution of any acute illness. Lipid profiles can vary up to 30 days post MI. And again, you want to monitor for secondary causes, also looking at fasting glucose levels, liver enzymes, elevated creatinines, TSH, and urinary proteins. Screening in children. You want to screen children that have known risk factors, especially diabetic patients, hypertension, family history of premature CAD, and you can start at the age of 2 to 8. With no risk factors, non-fasting or fasting can occur once before puberty and once at the age between the ages of 17 to 21. Primary lipid disorders, there's a strong genetic component. These are patients that have onset of premature atherosclerotic disease, less than 60 years of age. There's a family history of atherosclerotic disease, and these are patients that have serum cholesterols greater than 240. Again, here's just a chart for you. I would kind of memorize this. This does give the screening labs and the targets, and is divided within age groups also. Again, there's current guidelines. There's actually new guidelines that are that have come out just recently. The ACC and AHA guidelines, the key statement is with consideration of statins for patients who currently do not have atherosclerotic disease but are at risk of stroke or heart attack. We want to identify high and this identifies high and moderate intensity statin therapy for primary and secondary prevention. Again, new guidelines were published this year. There should be a handout that I included in the module for you. This emphasizes lifestyle modifications, and these remain the most critical component of reducing atherosclerotic disease. 4 groups that do benefit from statin therapy: obviously patients with known coronary disease, primary LDL levels that are greater than 190, patients that are diabetic between the ages of 40 to 75 years of age, along with an LDL of 70 to 189, and patients without diabetes who are, again, 40 to 75 years of age with an estimated 10-year risk of greater of 7.5. I did add the risk calculator link. It's really important that you use that and document for patients that you are considering starting lipid management for. I also added this slide. It's a little bit hard to read, but it just breaks down kind of a flow chart of when to start patients on lipid-lowering medication. Again, another chart to use. Again, it's kind of an easy flow chart. You can plug your patient in and see kind of where they fall and what type of medication to prescribe. Again, the current guidelines have the addition of non-statin therapies to statin therapy, which is recommended to be considered among all patients when with the additional LDL lowering medication is prescribed. There's also newer medications adding Zetia or PCSK9 inhibitors. Those are the new injectables. Should also factor into the patient's preference, cost, and route of administration. These 2 medications can be quite costly for the patient. Periodic measurements of lipids are recommended, including at the start of treatment, 4 to 12 weeks after the initiation of medication, and then every 3 to 12 months as clinically indicated. The American College of Clinical Endocrinology and guidelines from the European Society of Cardiology actually added an extreme risk population and management of those patients. So the management and treatment of dyslipidemia, obviously you want to either lower the numbers or increase that HDL. There are several medications that are used. There's statins, bile acid binding resins, cholesterol absorption inhibitors, fibrates, niacin, omega-3 fatty acids. There's, as I talked about earlier, new injectables, and there are some combination medications. I'll go briefly through all of these. Statins, their primary goal is to decrease the LDL and triglycerides, and they do have a slight impact on increasing the HDL. Their whole goal is to reduce cardiovascular morbidity and mortality. These do decrease the intra-atrial inflammation and systemic inflammation. However, you have to be cautious because 10% of these patients can develop muscle weakness, myalgias, and those complaints can be dose dependent. Adverse effects, you need to monitor patients' liver enzymes. They can cause constipation, nausea, diarrhea, cramps, and there's an interaction with grapefruit. Again, these medications are not safe in pregnancy. I did add some of the medications and the current doses depending if they're high intensity, moderate, or low intensity. The bile acid binding resins decrease LDL by upregulation of the hepatic LDL to biosynthesis. These medications are okay in the pregnant patient. They do interfere with the absorption of thiazides, beta blockers, Coumadin, digoxin, and thyroid medications. So you have to be very cautious when using these medications. Side effects do include, again, constipation, bloating, nausea. They do need to be given or taken with food. Some of the examples are Colostid, Prevolite, and Welchol. The cholesterol absorption inhibitors, they decrease LDL, slightly decrease the triglycerides, and slightly increase the HDLs by inhibiting the absorption of cholesterol. These are great choices for patients that are unable to tolerate statins. However, they can be quite expensive. Some of the adverse effects include fatigue, abdominal discomfort, and they can cause some minimal myalgias. An example of these medications is Zetia. In combination with statins, the medication name is Vytorin, and you may see lots of commercials regarding Vytorin medication. The injectables, the PCSK9s, they decrease LDL in patients who have a genetic condition that can cause very high LDL. And it's done by keeping the PCSK9 from attaching to the LDL receptors. LDL can be lowered by 40 to 70%. These medications have actually kind of been a game changer. However, they are very expensive. Many times you have to do pre-authorizations for these patients to be able to get these approved. You have to document that the patient has failed other treatments. The clinical trials have showed a decrease in cardiovascular events in patients with known CAD. But these are injectables, so you have to make sure that the patient is able to give themselves a shot. We do have some patients that actually will come into the office to have their medications given to them. Adverse effects include itching, swelling, pain at the injection site, and sometimes when they start these medications, they can have flu-like symptoms for a few days. These medications are given every 2 to 4 weeks. Examples of these are Repatha and Praluent. Fibrates are medications that decrease triglycerides and may increase HDL. Adverse effects is nausea, abdominal discomfort, and elevated liver enzymes. You have to be cautious and make sure that you're monitoring patients' liver enzymes when using these medications. You need to be cautious when using these medications with statins and also Coumadin. It can affect patients' INR levels. So these are examples of these medications include Tricord and Lopid. Niacin increases HDL by inhibiting HDL clearance. These are really good to add if you have a lipid profile that a patient has a very low HDL and they've tried lifestyle modifications to increase that and it has not been increasing. There's still research that needs to be done to adequately know if increasing the HDL actually decreases the risk of death. For patients that do have a low HDLs, lifestyle modifications may be the best option other than adding a medication. In large doses may also potentially reduce the LDL and triglycerides. These patients need to make sure that they take these medications, the niacin with aspirin. It will cause face and neck flushing. I tell patients to take it at night, so if they do have the flushing, they're less bothered by it. Other adverse effects include nausea, diarrhea, gout, elevated blood glucose, and itching. Omega-3 fatty acids, these can be actually not necessarily, they have to be prescribed. Patients can buy omega-3 fatty acids over the counter. Still, there has not been a whole lot of research, but patients have noticed a decrease in their triglycerides. It may also help increase HDL because it reduces oxidation. We do get omega-3 fatty acids from food. Having patients actually increase fish intake can also be an adequate way for patients to get enough omega-3 fatty acids. Adverse effects, the biggest thing is belching and a fishy taste. Examples of this obviously is fish oil. They, again, can be purchased over the counter. They're quite cheap. You do need to be cautious that it may increase the risk of bleeding and bruising. Probably the most important thing that you can do for your patients is educate them on lifestyle modifications. Obviously, reducing fats in their diet. They want to decrease eating fried foods. I teach patients that it's better to eat like the white meats, chicken, pork, make sure that it's baked, increasing fish intake, exercise, very important, weight loss, strict diabetic control, smoking cessation, and again, we need to aggressively treat their blood pressures. There are some secondary causes of hyperlipidemia. Obviously, sedentary lifestyle with excessive dietary intake of saturated fats, cholesterol, and trans fats. The diabetic patients have a tendency to have elevated lipids, hypothyroidism, hypertension, nephrotic syndrome, chronic kidney disease. Again, we talked about some of the medications that we need to be cautious of that can also increase lipids, the thiazide, diuretics, beta blockers, estrogen and progesterone, and glucocorticosteroids, cigarette smoking, other anabolic steroids, and HIV infections. Hypolipidemia, we always will get some referrals in cardiology regarding patients that have a low lipid panel. This is defined as total cholesterol less than 120 milligrams or an LDL less than 50. Primary causes are genetic or their secondary causes, and those include hyperthyroidism, chronic infections, hepatitis C, hematological and other cancers. If the patient is has a diagnosis of poor nutrition, and they could have issues with malabsorption. You'll want to, for these patients, also include an AST, ALT, TSH, serum albumin, and prealbumin to rule out some of the secondary causes. Again, I added some questions in here that you can review. That these are questions that you may be tested on. I'm not going to go over them right now. We can discuss them later in class if needed. All right, I think I'm going to end the presentation now. If you have any questions on hypertension and dyslipidemia, let's discuss that when we meet together on May 29th.